Well, thank you for inviting me to speak at the Narcolepsy Network. It was fun to engage in the medication or management panel earlier. um, so a lot of the questions or topics about, I think, treatments were addressed there. So I'm not going to spend too much time during this session, but we'll get more into kind of just the clinical presentations, diagnosis, and some management as well. Just by way of a quick introduction, some of you may know me. I am a neurologist by training. I finished my neurology residency in 2002, and then a sleep medicine fellowship in 2003, both of which I did at the Cleveland Clinic. I worked there for 17 years until moving to Philadelphia 5 years ago to work at now the University of Pennsylvania. And I also will say that I know this meeting was supposed to be in person, which I was very much looking forward to. And just based on the experience, I did go to a first concert in almost a year and a half last night to see Five for Fighting over at the Colonial Theater in Phoenixville. And it was a great experience, even with the masking and things like that. But hopefully one day meetings will go back to being in person. And so without further ado, let's jump into the topic that many of you are very familiar with. In terms of a quick overview, so you heard about the type 1 narcolepsy, type 2, main difference being, type 1 cataplexy is present, type 2 cataplexy is not present. And then you have another large group of individuals who have idiopathic hypersomnia. And if you think about it, it's mainly the diagnostic criteria that separates these people into these three categories. And in terms of how common are these groups of people who are sleepy, as you can see, the quoted number typically is about, the prevalence of type 1 narcolepsy is 1 in 2,000 to 4,000. Type 2 narcolepsy is less clear only because it's more heterogeneous. So it's even less clear in terms of how many individuals have idiopathic hypersomnia. And I just put that table here in the middle just to give you a reference as to, how common or uncommon is narcolepsy compared to other medical conditions you're aware of. For example, it's estimated that, eventually a third of the population will have hypertension, 10% of the population diabetes, sleep apnea is common, about 7%. Then you have the other neurologic conditions like Parkinson's disease, 0.001%, narcolepsy, 0.005%, then ALS is, very uncommon. Again, narcolepsy typically presents in the first or second decade of life. And I think this number was more based of less awareness and education. And typically it did take a long time for a diagnosis to be made, only because there are more common reasons for someone to be sleepy or have cataplexy. So then this brings up the question, what else can it be? And I think this is what leads to a delay in diagnosis for many individuals. And so there are definitely more common things that can contribute to sleepiness. For example, the most common thing, and I'm sure many of us are guilty of this, is just not getting enough sleep. We're a sleep-deprived society. 24 hours a day, things are moving and happening, and some people are working nights. And so you can see that just not getting enough sleep is common. Also, too, it may just be an issue of someone's clock being off, either too early or too late. And depending on when that person needs to be awake and functioning, then they may have a manifestation of their lack of sleep due to the clock being at the wrong time, of either not being able to fall asleep or being too sleepy as a result of sleep deprivation, or needing to stay awake during the middle of the time when you should be asleep. And this is the case for shift workers. Now, depression is very common. And so if you look at the criteria for depression, it's almost like a Venn diagram. A list of symptoms for patients who have depression are very similar to many symptoms that a patient who is sleepy can exhibit in terms of inattentiveness, low mood, being agitated or more irritable. And so depression, being as common as it is oftentimes diagnosed first, treated, so on and so forth. Obstructive sleep apnea also can present with daytime sleepiness. You can imagine that if someone is not breathing multiple times a night, that certainly can contribute to daytime sleepiness over time. Now, more neurologic, I guess, a structural lesion in the right part of the brain can cause sleepiness. For example, in some patients with multiple sclerosis, or if there's a brain tumor in the right place, for example, the brainstem, they may have a version of narcolepsy or certainly daytime sleepiness. And then last but not least, certainly you can't discount the impact of medication effects. Many people over time develop different medical conditions requiring multiple prescriptions. And I think there is more awareness, and with the assistance of pharmacists, this is becoming slowly less of an issue. But I think it is important for all doctors to take a good look at a medication list for patients before prescribing something new, to make sure that there are no interactions, in particular, those that may either make a person sleepy or make the current medications less effective. As was mentioned before in the setting of medications like modafinil and oral contraceptives. Now, in terms of narcolepsy, this is kind of the pentad of clinical features. For a long time, it was thought to be mainly the first top four. So everyone with narcolepsy, type 1, type 2, has to be sleepy. Cataplexy may or may not be present. You have the hallucinations, sleep paralysis, which can be normal. And then I think the last one is increasing in awareness and importance in terms of the presence of sleep fragmentation, and then how that does result in sleepiness for these individuals. Now, how do these manifest? Again, as I mentioned, everyone who's sleepy, and it's happening to the point where it requires kind of going to the doctor, or a person complains about it, or a parent especially notices that their child is inattentive, or being told by their teachers, getting reports home that they're falling asleep during class, or on the school bus and missing their stops. The most common thing certainly could be depression, or even more commonly, as was mentioned earlier, diagnosis of ADD may be made, and for that reason, medication can be prescribed. So certainly someone who's drowsy will not be able to pay attention too well. Individuals may be overcome by this irresistible urge to sleep, leading to either naps or kind of short sleep periods in the wrong time, such as the classroom or in the workplace. Now, microsleeps can also happen, and this is where an individual can actually fall asleep for very brief periods of time, maybe seconds, but not fall asleep to the point where it's noticeable to others. The head bobbing, or their heads actually goes down, meaning this can result in automatic behavior. And so you can imagine if you're driving on the highway, going home at 8 a.m. in the morning after a night shift, there may be times when patients say that, I know that I left the parking lot for my place of work, and then before you know it, the next day I remember I'm pulling to my driveway, and they have no recollection of what happened between the parking lot to their garage, which for some can be scary, because it's either because it's so routine that they just kind of didn't pay attention, or for some, it's actually almost like they're on cruise control while they're driving. And then finally, napping is something that can be normal, but in someone dealing with excessive daytime sleepiness, a story comes out where an individual who didn't need to before, all of a sudden needs to take naps, and then over time, these naps may not even be helpful. Now, cataplexy, we'll spend a little bit of time on this topic, because this is hard for even a skilled sleep doctor to identify at times. And then it's also very difficult for patients to identify, even those who are having episodes. And that's because, one, there's no test for it. There's no great questionnaire. I mean, there are some that exist, but nothing that's either simple, or kind of quickly administered. And also because cataplexy can be very, very variable in terms of what happens to a person. Now, in terms of general description, there's oftentimes by history, a trigger, usually a strong emotion, typically, happiness or exuberant laughter, or anger, or, extreme stress can bring on an episode of cataplexy. Now, the thought is that, does it have to be bilateral or the whole body? No, it oftentimes does affect, say, like both legs or both arms, but it can just affect one extremity at a time. And then the other thing too is that it is classically you lose muscle tone, but the key is that the person, when they lose muscle tone, are wide awake. And so that's the difference than someone passing out where they lose muscle tone, but then they're also losing consciousness. So then before you know it, they wake up, they see that they're on the ground, and they have regained muscle tone. But in someone experiencing cataplexy, I mean, you lose muscle tone, but you're fully aware of what's going on around you. Typically, the muscle groups that are affected your body, so the head, neck, kind of trunk, like shoulders, or the legs and knees. And I've had some individuals say that really all they have is kind of their neck may get weak, where they bob when they're telling when they tell a joke that they think that's funny, or the more subtle examples are, I think, the types of cataplexy that patients oftentimes realize, after we've been meeting for a while and they're on a good treatment for sleepiness. For example, I had one patient where that person was giving a presentation to a group of people that when it was her turn to present, oftentimes she would maybe slur her speech a little bit. I mean, not for the entire presentation, but at the start. And most times it was only something that she would recognize. But then once she was less sleepy and was on the right medication for narcolepsy, she realized that she had that happen less. And so I think we both came to the conclusion that that was probably her cataplexy, and that was something then to follow over time in terms of either response to treatment or need to add something else for cataplexy. As I mentioned, it's a partial loss of tone that is most common. What you see in the news or the movies or TV, people that they say have narcolepsy, all of a sudden, their food falls straight forward into their plate of food, or they collapse to the ground. That is not as common as the partial cases that we talked about briefly. And again, they're quick. Most times they last seconds to minutes. Many patients just say that they know when they laugh, they're going to get a little weak in the knees, certainly not enough to trip or fall. Or if it is more severe, they know that they should be sitting down, or they prepare themselves and still laugh and enjoy themselves. Now, hallucinations can be also concerning to not only the patient, but to friends and family, especially if the person having them talks about them. And then if a healthcare provider hears about it, time being short, that we spend with patients, they may jump to other things that are more psychiatric in nature, or from the neurology standpoint, if it's a stereotypic thing that is either heard, seen, or felt, that one thing that is more common, it could be, could this be an aura in terms of a seizure? And so that's where some of the delay in diagnosis can occur if, either hypnagogic hallucinations, meaning, these are things that happen while you're falling asleep, or hypnopompic hallucinations, meaning these happen as a person's waking up. And this can be both at nighttime or even around naps or unintended sleep episodes. And that's why you can see that it's not just one time a day, but it's really around any time a person is either sleeping or waking up that this can happen. Now, sleep paralysis is also a REM phenomenon that can be seen during wakefulness. And this consists of, again, muscle weakness at either when you fall asleep or wake up, and you're also wide awake. And so I guess you can kind of think of it almost like a version of cataplexy, but it's tied to that period of time right when you're about to fall asleep or wake up. When this happens, I'm told by patients that it can be very stressful and anxiety provoking. In the more severe cases, what happens is that a person's waking up and say that they have roommates, they hear them talking and they try to participate, but then they quickly realize that they're wide awake but can't say anything and can't move. And you can imagine what that would feel like. It feels like, they say that feels like it lasts for a long time, but typically it's very short. And also, one thing to remember is that isolated or recurrent sleep paralysis, can happen in patients without narcolepsy. Now, one thing before I go just to those neurotransmitters, that this is the kind of the pentad of possible symptoms associated with narcolepsy. Again, most people don't have all of them. I think maybe 20-25% ultimately may. I mean, certainly everyone starts with sleepiness, and then the next most common thing typically is the development of cataplexy for type 1 patients with narcolepsy. That cataplexy can present years after the initial diagnosis. So that's why it's important to, bring up something to your healthcare provider, be asking about this ongoing as they're seeing the patients. Now, in terms of, how do we stay awake? You've probably seen similar diagrams, and I'm not going to get into too much detail here, but to stay awake, there are 5 main neurotransmitters involved from different parts of the brain. Brainstem is part of it, but then also the basal forebrain. And so you have acetylcholine, that's the ACH, histamine, dopamine, that's DA, serotonin, 5-HT, and norepinephrine. And those are the main kind of neurotransmitters that are active, as I'm sure right now, as you're wide awake watching this talk right now, that those levels are high and those areas in the brain are active. And then you see orexin here, the other name for it is hypocretin. And those neurons are located in the posterolateral hypothalamus. And their job really is to make sure that these wake promoting areas that you can see are active when they're supposed to be. And then in terms of a theoretical construct as to how to put this all together, it's like, how do we stay awake? How do we sleep? Is this model that Dr. Scammell kind of came up with, which to me makes sense. And I try to explain this model to all of my patients, not just with narcolepsy, but just anyone who's sleepy or having trouble staying awake. And as you can, so this is a flip-flop model where you have 2 states. In the engineering world, you have state A and state B. So engineers can, depending on what they're designing, determine how long a person, or not how a person, how long state A is present. And then at some point, there's a threshold or a trigger. When you reach that, then you flip over to state B. So it could be a gradual switch or an abrupt one. For example, if all of you think just to last night and try to determine exactly at what point did you fall asleep. I'll bet that most of you can't come up with that number, but you can certainly recall the moment when you're very drowsy to the point where the next thing you remember is you're waking up at some point. So that's kind of an example of a slow transition where one moment you're awake, then you make that transition to sleep, and then before you know it, you're waking up again. And that waking up part, can be slow. That's, I think, where sleep inertia can come into play, where for some people, I mean, they're truly able to, once they wake up, can hit the ground running. Other people, it truly takes 30 minutes or an hour to become alert, and that's a circumstance where you can be awake but not alert. And also too, that can be one of the most difficult things to treat for someone with narcolepsy, where even with the right combination of medications to help them stay awake, with or without a nighttime medication, that the most difficult thing to treat is that waking up in the morning to start the day. So having said that, so when we're sleeping, the opposite happens. So the switch flips, as you can see. So here on the right side, when you're awake, these areas are active with the wake promoting neurotransmitters. And then the left part indicates when that VLPO stands for the ventrolateral preoptic nucleus. That's the area of the brain that through GABA, which is a neurotransmitter that's inhibitory, helps promote non-REM sleep. And so the top part indicates when a person's awake, and then the bottom indicates when you flip over into sleep. You can see that on the right side, the wake promoting areas are being inhibited by GABA from the VLPO on the left. And also too, you can see that there's also a projection to the ORX, which is the orexin. So you have a double break, meaning on the wake promoting areas and also on the part of the brain that makes orexin. Now, in patients with type 1 narcolepsy, if you eliminate that green dot, this is where you have a concept of an unstable flip-flop switch. And so one way to think about this is that patients with narcolepsy can stay awake and they can sleep but because of this unstable switch, they're going back and forth from state A to state B. And that's the difference in someone with narcolepsy to somebody without, where someone without narcolepsy should be able to stay awake for most of the day. I mean, if they're not getting enough sleep, they may be hit by, sleepiness or hit a wall in the afternoon. Whereas patients with narcolepsy, no matter how much they sleep, you can see that during the course of the day, at one moment, you're able to stay awake, but then quickly you may be overcome by an irresistible urge to sleep, that sometimes you may be able to overcome, but without medication, then you're going into the sleep state, and it doesn't have to last long, but then at some point you go back to being awake. So depending on the degree of narcolepsy, that can also, I think you can use this model to kind of see where you are in terms of treatment response and kind of how things were in the past. In terms of the criteria, this is based on the International Classification of Sleep Disorders, 3rd edition, where you have type 1 and type 2. Sleepiness is common to both. Both do require the overnight PSG with the daytime MSLT. And then you can see that cataplexy is present with type 1 and cataplexy is absent with type 2 narcolepsy. And the new exciting way to, help make a diagnosis is looking for spinal fluid hypocretin levels. Hypocretin, again, is another name for orexin. So in type 1 narcolepsy, it's reduced, if not absent. And then in patients with type 2 narcolepsy, you do have CSF hypocretin levels that are detectable. And again, it's important to make sure that there are no other causes of the sleepiness in these individuals. So to make a diagnosis, a lot of it is by history. So certainly, by the time a patient ends up seeing a sleep specialist, they may or may not have been dealing with this for years. And so that's part of our job, is to really get a clear history, not only currently, but going as far back as possible, that a person affected with or without input from family members, that to get a paint the picture of how long has the sleepiness been going on for. And then one thing that oftentimes is a clue is that for some individuals, narcolepsy can start after a significant head injury or a viral illness. And so those can be, certainly risk factors to either identify or highlight if no one's asked about that before. And that kind of helps pinpoint, like in 6th grade, I had mononucleosis, I recovered, but then after that, I've been tired, sleepy, that kind of thing. That's a common story. And so it does take time for some individuals to really go deep into their past to really figure out how long has this been going on for. Then comes the testing, typically the overnight polysomnogram followed by the daytime MSLT. And then I think the spinal tap is needed typically when either the sleep studies are inconclusive, as was touched upon earlier in the panel discussion, or there are some individuals where they do have cataplexy, they're sleepy, then there's other things going on, where meaning other possible reasons for loss of consciousness, meaning like an overlap of syncope and also seizures, meaning that there are some patients with epilepsy who can have narcolepsy. And so depending on how management of the other conditions is, it can be helpful at times that I've come across to order this test. And then if the spinal fluid levels of orexin or hypocretin are low, undetectable, then certainly that can help make a diagnosis of narcolepsy in some individuals with many other things happening at the same time. And there was a question earlier about the reliability of the MSLT. And this just touches upon a little bit of that, in that certainly it's a non-specific test. I mean, it's been validated in the context of diagnosing narcolepsy with the parameters of a mean sleep latency of less than 8 minutes, and also the presence of 2 or more sleep onset REM periods. Remember that REM sleep typically doesn't appear until a person's been sleeping for at least about 90 minutes or 110 minutes, so rounds it out about 2 hours. So the fact that in a 20-minute nap trial, because this MSLT consists of 5 opportunities during the daytime at set intervals to get into bed, and your task is to fall asleep. And so this daytime test measures how quickly does this person fall asleep if they do. And then also after they fall asleep, is there evidence of REM sleep? So any REM sleep in a 20-minute period is not normal. However, as many of you are probably well aware, there are other conditions and circumstances that can result in the presence or absence of sleep onset REM periods. So if you're sleep deprived, you can have REM rebound. Also with someone who has a very delayed circadian rhythm, at the time of the test, there may be a REM period if that's the, and then also too, there may be environmental causes for uh, inaccurate sleep latency. For example, if there's a lot of noise outside, depending where the sleep lab is, if there's like an ambulance bay or a helicopter, landing pad outside the room, then if those kind of noises interrupt someone, then that may falsely result in a false negative test. And then also too, just keep in mind that up to a third of MSLTs can go either way, false negative or false positive because of all of these reasons. And the issue about medications came up earlier. And if a person is on a REM suppressing medication, typically an antidepressant, that can result in maybe either missed or decreased number of sleep onset REM periods, or if they're in the process of either stopping or weaning off without the proper amount of time for things to equilibrate, then say, for example, if someone was taking a potent REM suppressant, stopped it a couple days before the MSLT because they forgot to stop it, 2 weeks before, then that with acute withdrawal from the medication may result in a REM rebound that may result in a false positive result. And for those of you who are older or have dealt with narcolepsy for a long time, up until the availability of the spinal tap to look for orexin levels, this test could be done to look for HLA typing, specifically the DQB1060 allele. Only issue with this test is that up to 25% of the normal population can be positive for this allele. So as you can see, it wasn't the best screening test for narcolepsy. And this is just a screenshot of on the Mayo Clinic website. This is where we would send spinal fluid samples if you were to get a spinal tap to get tested for your orexin hypocretin levels. And I just wanted to put this picture in for those who have heard me talk before. You've probably seen it, but this is basically initially what I learned about it was that it was taken by Lewis Hine, who was a sociographer in the 30s, supposedly commissioned to document the building of the Empire State Building. And as you can see, the more famous picture is, I think, is lunch in a skyscraper, where you've seen these guys sitting up and eating lunch on a girder, well above the ground. So when I actually looked this up again, apparently this picture was attributed to the wrong person. Charles Ebbets is the person that probably took this picture, and it wasn't the Empire State Building, but it's actually the Rockefeller Building. I mean, either way, they're high up above the ground. And I can't imagine anyone doing this on a girder. So then it turns out that probably these pictures were staged as well. I mean, even so, it's still a pretty dramatic picture, just to underscore the importance of taking a break and taking a nap, no matter how, I guess, you don't have to do it in this dangerous fashion. And so there was questions about, the role of non-pharmacologic treatments earlier. And I think this should be across the board for all patients, with narcolepsy or even like just sleep disorders. Sleep hygiene is crucial. This is the toughest part though, too, especially if a person is busy with, working, going to school, but then also, if you have family and then also are working and going to school, you can imagine how tough that can be. The easiest thing to get rid of is sleep. So it's really important to prioritize sleep, to make sure you get enough. And so really to do whatever you can to minimize sleep deprivation. As was mentioned before, that if a person does not get enough sleep, even the most effective medication may be less effective. And so it's to make sure that if you're going to take something medication-wise to maximize its benefit, make sure that you're getting enough sleep. And then if possible, short scheduled naps can be very helpful. And again, this may not be possible for all people, especially depending on the work condition. where sometimes accommodations may need to be requested. I'll talk about that in a second. And so if possible, I mean, we're talking short naps, 10 to 20 minutes, if as long as they're refreshing and not too late, that can be very good, especially if they're done strategically. And oftentimes what helps patients is that if someone is taking medications twice a day, stimulant or a wake promoting agent, for the second dose, it can help to take it, put your head down, and then by the time you wake up, it's starting to get absorbed from your gut, and so it maximizes both the benefit of the short nap and the second dose of a medication. And then finally, make sure that no other contributing sleep disorder is present that may be also contributing to daytime sleepiness. Let's see. And this was, as you heard Dr. Cron's keynote talk. I mean, she went to way more detail about this. So again, this is just a quick summary about different medications and available for sleepiness, starting with the traditional stimulants like the amphetamines until the introduction of modafinil, armodafinil, and then most recently 2 years ago, solriamfetol, and then the other group of medications, the oxybates, and then the pitolisant, which is also very novel because it works through the histamine system. And then in terms of cataplexy, as you heard earlier, the mainstay until the novel agents were available were off-label use of antidepressants. Now, in terms of goals of treatment, again, we touched upon this, but it's really to maximize function in school and the workplace. And a common thing that does come up is that everyone wants to be normal, and I totally understand that. However, what I tell my patients typically is that I can help them to be normal like really quickly, but if that requires you to take a maximum dose of all the medications right now, then if narcolepsy gets worse, or if your body, depending on how it metabolizes medications, develop tolerance to the medications, then there's nowhere else to go. So my goal is to get you to close to normal as possible. And for many, that's pretty much normal, so that's good. But it's a matter of keeping an open dialogue as to kind of what the goals of treatment are, and also kind of managing expectations, not only for the patient but also for the family, and also for the employer or school if needed. Overall, trying to decrease any disruption that can occur from this intrusive sleepiness and cataplexy if it were to occur, leading to the accommodations if needed. That's also important for people to be aware of certain things that they may not be able to do. For example, at the federal level, I know that patients with narcolepsy aren't allowed to have commercial driver's licenses, so that if you want to be a truck driver, you wouldn't be able to do that, even with treatment. And so be aware of potential limitations and also the stigma attached to just being sleepy. I think a common thing that I've heard over the years is that, until a diagnosis is made, patients say that, oh, everyone thought I was lazy because I was sleeping all the time, like napping, things like that. And so when really most patients with narcolepsy do quite well, it's just that they have to work twice, if not 3 times as hard to reach the same goal as their friends or peers without narcolepsy. Now, in terms of future directions, just a brief comment. I mean, we talked about the MSLT and the limitations. There is this spinal fluid test now that we can look for erection. Now, it'd be great to have a blood test, of course, that's reliable to look for this, so you don't have to get a spinal tap. And I will say that in the hands of an experienced person doing it, it's not so bad. I think a lot of patients hear horror stories, of course. You always hear about the bad cases. And so that kind of scares them away. But as a neurologist, when I did that a long time ago, as long as you kind of ask the same question like a surgeon, like how many have you done? And then, things of that nature, your experience shouldn't be bad. And then also too, in terms of a better assessment of sleepiness and alertness, I think this is crucial because currently we rely upon a, either subjective report from patients as to how they're doing. It's like, hey, after taking this medication, how do I feel? It's like, I'm awake, I don't need to take naps. The number of episodes of cataplexy. So there are things that are quantifiable, but even more importantly is helpful to, get some sort of biomarker for sleepiness, either, after a person's been awake for X amount of time, even in the absence of reported symptoms, are they affected? Because notoriously, Just similar to someone who's had too much to drink, you ask them, are you drunk? Usually they'll say no, even though they're slurring their speech and they're stumbling. So oftentimes patients, or people, not just patients, but just people who are sleep deprived or sleepy, they'll deny having any issues with staying awake or with attention, things like that. And then when they do certain tests, they have lapses or problems. And one example of such a test is the psychomotor vigilance test, the PVT, where it really is a good measure of alertness per se, not necessarily sleepiness. So as a proxy, if a person has a hard time focusing or paying attention to the task at hand because they're sleepy, then they'll either make mistakes or over anticipate and then may have too many responses. So something like this, the PVT, would be great to have in a clinical setting. It's been well looked at and utilized in research settings to kind of look at how people are doing with treatment and changes in treatments. And then, the last thing is back to the medications. There are other medications in the pipeline, but the one that really seems to have a lot of promise is acting at the site of where something is missing. So an orexin receptor agonist would be great to have in the armamentarium for patients with narcolepsy. Now let me try to figure out how to see the questions. I'm sure there's some that have accumulated. Okay. Let's see, just give me 1 second. So at the top, are there any other conditions, sleep related or not, that can produce cataplexy? Yes, I think I touched upon that, where anything that can cause sleep deprivation, medication effects can result in cataplexy. There's also some nice studies to show that patients with sleep apnea can have, sleep onset REM periods. Cataplexy, so again, if it's more of a neurologic issue, depending on if a part of the brain is affected, for something like multiple sclerosis, that can result in cataplexy. But typically, cataplexy is pretty specific for narcolepsy, which is why it's part of the diagnostic criteria. And so, and also, two, the things that I mentioned before in terms of not getting enough sleep, that can exacerbate cataplexy as well. And so I guess then it's a question of, is it producing it, or what can make it worse even with the appropriate treatment? So that was there twice. There's one, let's see. Sorry about this. So one question is, so NT2 has normal hypocretin levels always? Well, if you look at the studies that looked at hypocretin levels in patients with type 1 narcolepsy, type 2 narcolepsy, and normal controls, what you'll see is that patients with type 1 narcolepsy, it's almost zero or undetectable. And then also what you see in the normal controls, they're the norm. But hypocretin levels, I think, were found to be decreased in patients with type 2 narcolepsy, maybe less than controls, but not zero. So that's where I think the heterogeneity of those patients with narcolepsy type 2 makes it a little bit more difficult at times, one, to make the diagnosis, because it's really reliant upon sleep studies. And then also that's why I think there's variability in response to treatment. Let's see. Okay, and then one person asked, can I speak to the proposed reclassification of narcolepsy, idiopathic hypersomnia, and the narcolepsy borderlands? It has been proposed to get rid of NT1 and NT2 and only have narcolepsy, with cataplexy or NT2 plus HLA biomarker, idiopathic excessive daytime sleepiness, NT2 plus IH short sleep, and new IH with long sleep time. I mean, I think the more we learn about sleepiness, in particular narcolepsy, type 1, type 2, and then also idiopathic hypersomnia, I think the more specific and detailed we can be in terms of making the diagnosis. I think even if you look at other medical conditions, say like 20, 30 years ago, you can see how the diagnostic criteria over time has evolved to be include more evidence and more information as we discover it. I mean, perfect case is, diabetes and hypertension. You can see, like 100 years ago, how did they even, measure blood pressure reliably? Even back in the day, I guess once you may hear that the way that early doctors diagnosed diabetes was by to basically taste a sample of urine. If it was sweet, that means that, which shouldn't be the case. I know it sounds gross, but before tests were available uh, to make these diagnoses, that's where we were. So it's kind of like, I mean, with narcolepsy, following the same pathway, we're doing the best we can with the information that we have and the tests that have been looked at to make the diagnosis. But as this person asked, I think, with the proposed reclassification, it totally makes sense, which incorporates more of what we know in terms of symptomatology, the an HLA biomarker, orexin levels, and then I think that way it can do better studies to see which treatments are better or not. Because right now, I think a lot of patients are lumped into these categories, where if there is a specific marker that could help differentiate clearer, you know, uh, NT2 versus idiopathic hypersomnia patients, then the drug trials may be better. And then you can really say, hey, it's for, this group of patients with this criteria that this medication would work. And we're just starting to get that information, which is really exciting. And I know this is a narcolepsy conference, but with the approval of Xywav for idiopathic hypersomnia, I think that is a recognition that there are other treatments that can be helpful for patients who are sleepy. And again, and so big picture, I think a lot of work still needs to be done to phenotype. Another word for that is create a profile for each of these types of patients, with or without cataplexy, but then say that the traditional testing methods don't, the person doesn't fit into that category, but they're still sleepy, then what else can be used to best identify what the diagnosis is? Understanding that if you take a step back, many of the treatments that are used are very similar. And I think in this day and age, and this was alluded to before, sometimes we do more testing or do more trials of off-label medications or on-label medications only because things are not covered. The newer treatments are more expensive. So that's just the reality of healthcare in 2021. Let's see. What is the difference between a sleep attack and cataplexy? How long do episodes of each last? So the main difference between a sleep attack and cataplexy is this. So remember, cataplexy is a partial or complete loss of muscle tone, oftentimes triggered by some strong emotion. And the thing that makes it different than a sleep attack is that during an episode of cataplexy, even full-blown like severe collapse to the ground, is that wide awake. I mean, there's no inkling that you're sleepy, and that's the reason why you may fall. It's not because you were lightheaded and passed out. You're awake. So extreme examples would be, someone collapsed to the ground, Good Samaritan comes over, starts doing CPR, but it's cataplexy. So then when the cataplexy episode passes, the person affected jumps up and, throws the guy off saying, I'm fine. And so that's the difference. Where a sleep attack, a person affected by that is, overwhelmed by this irresistible urge to sleep, and they just can't fight it. And so they're actually falling asleep. And depending on what position you're in, that may result in you slumping over, or, I guess in extreme cases, this could look like you're falling. And so hopefully that answers that question. And then let's see. And then do I have any experience in or read about neurofeedback to help with symptom management? I have heard about the role of, neurofeedback, for some individuals, but again, I have no experience with this. But in the hands of a good neurofeedback practitioner, that may help, manage some symptoms. And let's see. So I think I have 20 seconds. again, thank you for attending on this nice afternoon, at least in Philadelphia. The weather is fantastic, so I'm hoping to get outside soon. And I hope you guys got something out of this. Thank you.